Hello and welcome to the Frontline to Finish Line podcast, your go-to sport and exercise medicine podcast series. I'm Claire Spear, a specialist MSK and aquatic physiotherapist.
And I'm Dr Ed Appleby, a sport and exercise medicine specialty trainee working across MSK services and elite sports team in the Northwest.
Together, across this series, we'll be speaking to a number of industry-leading experts, exploring some fascinating topics across the multidisciplinary world of sport and exercise medicine.
We're delighted to have you join us, and we hope you enjoy the listen.
So today's podcast, for Frontline to Finish Line, we're welcoming Dr Jon Houghton. We're delighted to have Jon on board today. He is a consultant in rheumatology and sports medicine and works out of Fortius Clinic in London. He's a Chief Medical Officer for the Football Association of Wales and for Surrey County Cricket Club, and regularly consults to multiple professional football clubs, the RFU and county cricket. We've brought him on today because he has a real specialist interest in the management of tendinopathy, but more importantly for us today, bone stress injuries, with extensive experience in managing PARS injuries. So thank you so much for coming on the podcast today, Jon. We look forward to picking your brains about PARS injuries. For anyone with minimal understanding of PARS injury, can you just give us an overview of what's meant by that? What's a PARS injury fracture and how you define it?
Yeah, so a PARS injury is probably one of the most common injuries of the lumbar spine in adolescent athletes. So interestingly, we just don't see this in kids that aren't particularly athletic. So it's very much a sporting problem. I'm not going to go over, obviously, the whole anatomy of the spine, but essentially the pars, or the pars interarticularis, is the little bit of bone that goes between the facet joint above and the facet joint below in the posterior element. So you have the pedicle just coming off from the front, and then the lamina behind, and then the pars in between the facet joints. So it's quite a small piece of bone, but it's very much prone to stress in the adolescent athlete. Now, there are probably a small group of people who get injuries to that area at about the age of between 4 and 6, which is probably more developmental. But it's almost exclusively then in athletes or very athletic kids. So the more kids that do a lot more tend to get these sorts of injuries from about, we see them coming on at about the age of 12, and they go up all the way to about 20 in most sports. And then there are certain sports like cricket where they're particularly prone to this particular injury. In terms of PARS injury, it's really, I think it's helpful to see it as a spectrum disorder in the same way that we teach that all bone stress injuries go through a spectrum. And that starts off at completely normal bone turnover, i.e. physical activity increases bone turnover in an area. You have an increase in bone being depleted and then made, and an overall net gain with activity in that bone. So there's normal bony turnover that we see in athletes. If that becomes or starts to become pathologic, then we see a bone stress injury, and I'm sure we'll talk about the imaging a lot later. But what we'll see is a bone stress injury, and this is normally when the adolescent or the young adult starts to become symptomatic. If that continues and they continue activity, then that can turn from a bone stress injury into a fracture, a break in the bone. And the fractures can be either partial, i.e. a small area of the pars, or complete. And in some kids that might be, the whole of the pars might be 12 millimeters. So it's a small bone. So a small fracture might be 3 or 4 millimeters. It can go all the way through the pars. So I think when we're thinking about, the sort of spectrum of conditions, it's normal remodeling to stress to partial fracture to complete fracture. And then in those with a complete fracture, some of those may heal, but it's one of the high-risk stress fractures for non-union. So we also talk about chronic PARS, and a chronic PARS is when the fracture is complete and it's not healed and time has passed, there's no inflammation around the area, doesn't mean it doesn't cause pain, but it's not trying to heal anymore, and you get fortification of those two ends and it becomes a chronic non-union. So think of it as a spectrum disorder from normal bone turnover all the way through to a chronic non-union.
Brilliant. Thanks so much. Hi, by the way. That was really interesting. So obviously you talk about it being a spectrum disorder, so it might be difficult to answer this with a sort of definitive answer, but how do we usually sort of see the presenting athletes and active individuals, and what are the sort of key determinants of PARS type back pain versus your sort of regular type of mechanical back pain for other causes?
Yeah, so I think the first thing to say is that back pain is very common, but you have to counter that by saying it is normally, self-resolution over a period of days to weeks. So I think especially in a child, what we know from the data is that if you have somebody under the age of 18 that's pretty athletic, and they play a lot of sport, if they've had back pain for greater than 2 weeks that's not self-resolving, the data suggests there's a 40% chance that that is a PARS stress injury, which 40% doesn't sound big, but 2 weeks of back pain in a kid, I think 40% is a big number. That's a large number of those adolescents will have a stress injury of the PARS. Now, the presentation can depend a little bit on the sport, but on the whole, the most typical presentation is localized unilateral back pain on physical activity or shortly afterwards. So that might be on specific activities with their sport, or it may just be generally the more they do, it starts to stiffen up. It tends to be localized without any radicular pain, without radiation. I'm saying this as a generalization. We'll come on to some of the more severe ones later. But often in the early stages, it's pain on activity, which then settles when they stop the activity. And by the next morning, they're fine. And off they go to school and the next sports practice, etc. And this is, I think, one of the difficulties because often it settles. So parents, always well-meaning, or other people involved with the sport are like, well, maybe they're just a bit stiff or they've done a bit too much and don't really link the two together. But that's the typical presentation. Now, certain sports, for example, cricket, I mean, that's where most of my experience has come from. It tends to happen in bowlers. So if they're a right arm bowler, we typically see a left-sided PARS stress fracture or bone stress injury. And that's because of the bowling action very specific to their sport. So that part of the lumbar spine is going through flexion, extension, rotation, compression, all the forces that are going to put a lot more strain on that. Now, other sports, it can be completely different. It may be unilateral, sometimes bilateral. So depending on the specifics of their sport and their movement. As the problem starts to move more from bone stress injury to a potential fracture, then we start seeing that the pain starts going up. It starts being a bit more consistent. They might get it hanging out into the night with a bit of night pain. It might be a bit stiff in the morning. They might start to feel it on simple activities of day-to-day life. But I would say there's still a good 75% will come in only with pain on their specific sport, and there'll still be a PARS fracture.
And just sorry, there's a really quick follow on from that as well. Is there any specific examination tips that you've got for when you've got them in the clinic room? Things like point tenderness, particular movements, anything that would really spike your interest if you saw that in a patient?
Yeah, so this is where it gets really difficult. We might talk about this a little bit later as well, and I see this in a lot of bone stress injuries. So, we typically see, let's just take a stress fracture of the hip. Often the athlete has been continuing for a month or so with these symptoms and the clinical examination is normal. bone stress injuries can be difficult to induce in the clinic room without recreating their sport specifics. And that's very much the same for the PARS. However, what I would say is the sort of things that do tend to aggravate, typically we sort of hang our hat on the stalk test. So where they're going up on one leg and they're extending and rotating. That's a good way to try and bring on their symptoms. I think that the sort of quadrant test of just when they're standing, where they're going into some sort of rotation and extension, can be aggravating in certain individuals. And then on the couch, one of the physios that I do a lot of work with this has kind of put me onto this one where like a single leg bridge in that athlete can actually upset their pain. And they sometimes have some localized tenderness or guarding. But again, like I said, in the early stages and certainly with a partial fracture, you may only find, you may have a completely normal examination.
Yeah, I think that's one of the challenges, isn't it? Especially with sometimes these youngsters that it might be the first episode of pain, discomfort. They don't always know how to present their history, in a way that's understandable either, and that can be a challenge.
Yeah. And I think a lot of physiotherapists also that see them first off, if they're not used to seeing that injury, can be falsely reassured by a relatively normal examination with maybe a bit of increased extensor tone in the muscles. So that's one of the difficulties of managing this.
Yeah, I suppose not want to skip ahead too much, but for me as a clinician, as a physio, because I've seen quite a few throughout my career, my level of suspicion is quite low. So if I have, what you said, any very athletic kid that has central low back pain, I generally am referring them off for investigation. So, what is there a certain level of suspicion you would say to physios to have? Would it be just building on everything you've already said, or is there anything specific that you think I want to see this particular type of athlete in my clinic?
Yeah, I think we've got to think about what's the differential. And, there are a number of differentials with these. Certainly, if it's a central pain, then sometimes you can have like a ring apophysis stress injury to the spine. It's unusual, not impossible, but it's unusual for the younger athlete to have significant disc injury, significant facet arthrosis or inflammation. So I think that going back to what we said at the start of the 40% rule, if they've had pain for 2 weeks, then 4 out of 10 of those kids have got a past stress injury. Then we should have a very low threshold for imaging if they've had more than 2 weeks of pain. I think if you're a first line clinician seeing this as a physiotherapist, for example, then you might say, okay, we're going to do a certain amount of treatment. We're going to start them on some simple exercise. We're going to pare back from a little bit of activity for a few days, and then I'm going to see you in a week. If that is still there a week later, then I think you've got to have that clinical suspicion that we need to rule out a PARS injury. And it's, I would say out of all of the MRI scans that I do looking for this, I think it's normal about 1 in 10. I guess, I'm slightly lower down the food chain in terms of it's coming to me a bit later, but it's unusual for me to see normal scans by the time they've got to me.
Yeah, absolutely. And just to build on everything you've talked about there, which has been really helpful, are there any other risk factors? So anything else that you would consider asking the young athlete about that might lead you down the line of suspicion?
Yeah, I mean, I think like we've said, we need to have a fairly low level of suspicion anyway. But I think in terms of risk factors or things in the history, what I'm asking them is trying to paint a picture for not only what is the risk of this being a PARS injury, but also what are the additional things that potentially we need to treat and address to prevent this being a problem going forward or recurrent bone stress injuries. So I think that, the things that we tend to see is around their growth. The two periods that I tend to see it the most are in the sort of late stage or just after their peak height velocity. So not exactly during, it's slightly after that. And I think in the more strength sports like junior rugby, for example, I tend to see a big spike when they've been through their growth spurt and been fine, and then they go through the widening spurt. They suddenly get a lot stronger over 12 months, which just means that they're shifting a lot more tin in the gym, and the force is going through a much higher. So looking at them in terms of their athletic development, are they in those high risk zones? I think the ones also where you're much more concerned are where you take a sort of history of what's their physical activity, where, excessive hours, excessive days, we all know the kid that is going to be playing 7 days a week between school PE, club, county, professional academy, and they're playing all of these with lack of communication as to what's their overall load. Parents are just, whizzing them around between the various places, and they might have some days where they will have, play a full game at school and then go to academy training in the evening. I think that comes down to some of the factors around it, and we know that most bone stress injuries have a huge relevance to diet, and that's not only how good is their diet, how clean is it, but what's the timing of their intake. And again, is there, school swimming or club swimming at 5 o'clock in the morning, 6 o'clock in the morning, netball practice at school, then hockey with their club afterwards. Are they getting adequate carbohydrate? Are they getting adequate calories pre and post this training, which we know is a massive risk factor for bone stress injuries? I think vitamin D levels are traditionally lower now than they used to be, and that's partly because we live a more indoor life. So I'm looking for, are there any dietary intolerances? Are they children that don't like to drink much milk? They don't have much dairy? Is their diet too clean? Just not enough of the stuff that they need to fuel this huge need of calories and nutrients when they're growing? So I think those are the sorts of things that I'm looking at. Interestingly, there's not a great deal of data in PARS injuries with early sport specialization. There is a reasonable amount of data suggesting that those children that do early sport specialization have more bone stress injuries, but that's not very specific for PARS injuries. But I think we can extrapolate out from that and say if they are only doing one particular sport, let's say gymnastics and nothing else 7 days a week, then those are the sorts of things that kind of pique my interest. But like I said, the clinical suspicion is high. It's more about how we're going to manage this, both with the young athlete and the parents, and educate them about how we are going to prevent further bone stress injuries later down the line.
Yeah, it's one of the big tasks, and I think, to be fair, in addressing those risk factors, sort of started to feed into a lot of the management and a bit of the prevention type issues as well. I was going to ask a little bit more about prevention. Obviously, we touched on load, training modality, nutrition. Are there any other tips or anything you've seen in sort of elite sports settings that you've seen used for injury prevention in asymptomatic individuals? Or would you recommend anything like screening for asymptomatic individuals or anything like that?
I think, yeah, screening is interesting. And we know that at the very top level of athletic performance, and that's not just in adolescence, if you screen asymptomatic individuals in elite sport, you will find evidence of bone stress. So there's a couple of nice papers around elite tennis juniors and pars injury and other bone stress injuries. There's good data from rugby on asymptomatic screening pre-season for bone stress around the pelvis. The ECB tend to take their very elite level and screen them at the end of the season. They're young bowlers, young fast bowlers, and they get a pretty decent pickup. It's not insignificant, the number that have a bone stress injury, and they will have a very proactive way of managing them, but they have the data to show that even if they're asymptomatic and they have a bone stress on screening, if you don't pair them back, they develop a fracture. Might not be next week, the week after, but 2 months, 3 months down the line, potentially. So they have good data on that. And that if you do manage them with a deload and then progressive overload, then you reduce their return time to play. So I think that screening realistically from a cost perspective is going to be only at a very elite level. Now, as we see the cost of MRI coming down, we might see more screening, potentially, not certain. But I think that in terms of prevention, it's really much more around the education piece. And that I would say is in the 3 areas of what we've talked a bit about already: calories, carbohydrate, vitamin D, overall load and rest periods. And the other thing I think is, especially in strength sports, where strength is a big part, I think, I saw this with my son when he was kind of 14, 15. He was playing school rugby, and he was using the gym at home and shifting some serious weight, but he did it very, very sensibly, actually. But I saw his mates would come round, and it was very much, maxing out all the time. Is how much can you lift? So big axial loads without a good volume of preparation. And so I think, again, education around how to lift and how to moderate load within S&C and sports clubs and schools is a really, really key part of getting this sort of message out there.
So vital. I think picking up on when you've done your scan and you've diagnosed that person with having a pars stress fracture or stress response, how often would you then want to scan that person going forward? What would be the advice that you would give?
Yeah, so this is a really grey area, and I think first of all, it's probably best to kind of just go through the scans a little bit, so that people are completely clear. And this is fairly true for most bone stress injuries, not just pars. On the whole, X-rays are, your bang for your buck on an X-ray is not that great. So it's going to miss a significant number of bone stress injuries. It will also miss a significant number of partial fractures. It's a reasonable dose of radiation of the lumbar spine. So, when I was at medical school, I remember being taught about the Scotty dog X-rays. I think that, the X-ray is not particularly helpful. And I think that you don't get enough information from it for the cost of the radiation dose. So we'll kind of park that to the side. Previously, people used to do nuclear medicine bone scans, and it wasn't that long ago that it was still a pretty routine test for all sorts of bone stress injury. Again, big dose of radiation, not particularly specific. So again, I think let's put that to the side at the moment. So then we kind of get onto either CT or MRI scan, and without a shadow of a doubt, your first line investigation, or certainly it is for me, and I think there's really good validation for this and other bone stress injuries, is MRI scan. Now, MRI scan the benefit of it is no radiation to the athlete. That's really important with children. Also, it's quite repeatable, so it can be used for monitoring. It will show areas of mild bone stress, and it will show if there is a complete fracture. Now, where MRI starts to fall down a little bit is in bony anatomy, and CT is fantastic for that. So if we go back maybe 5 years, then it used to be kind of MRI for diagnosis, see the bone marrow edema, limited CT scan to look at the bony anatomy. Is it partial? Is it complete? What are the stages of healing? Now, thankfully as well, one of the things that's come along more recently is the vibe sequences, and there are various other names for it. Vibe is just for the scanner that was first used and the one that we use at Fortius. Now, what the Vibe does is it takes a T1 image and it does an inversion sequence on a breath hold, which then we can call a T1 Vibe. And that gives us a pseudo CT. And there are some really nice papers from 2017, 2018, validating CT versus Vibe sequences in past fractures. And it was about a 97% pickup sensitivity, which I think, you know, for the benefit you get in multiple scans and no radiation. Therefore, for me, if you're suspicious of this, we should be referring to an MRI unit that has the capacity to do an MRI with Vibe sequences. So it's a volumetric 3D reconstruction. Now, that's fairly slow getting out the blocks around the country, but I think the message is definitely getting across and the protocols are relatively straightforward. And I think that more and more sports clubs are demanding that of their local referrers. So we're seeing more kids at their local hospital, if they have the MRI, having these Vibe sequences. There's a big difference between a good Vibe and a bad Vibe, and we see some that are not proper volumetrics and they've just done a T1 and invert it. They're not diagnostic, so you need to have your relationship with your radiographer, radiologists to get these images. But we published a couple of years back at Fortius and the first Elite Athlete series on Vibe images, and that's our standard go-to for these. Very occasionally, we might consider a CT scan, and that's normally in an elite pro athlete if there is any doubt and we need to make a decision. And even more rarely, in a small number of professional athletes, we might consider a SPECT CT. Those tend to be in cases where they may have had multiple pars fractures in the past. They may have had a fixation. They may have had another spinal surgery or another diagnosis, and you're trying to say, what is it? Is it the facet? Is it the pars? Is it a disc degeneration that's causing this pain? But I think for the benefit of this podcast, I think people just need to get in their head that an MRI with a good Vibe sequence is the first line of management. It's very repeatable. And with good radiologists getting used to scanning these, you should be able to make a few more decisions around their management. That's a very long-winded answer to your initial question, which is how often should we scan? And the answer is nobody really knows. My personal experience, and I'll try and keep it straightforward and without complicating it too much. I think in our paper that we did at Fortius, what we saw was that it goes through various sequences on the scans, and it does depend a little bit on when you scan. So you can be a bit caught out in people where you scan them and there's quite bright bone marrow edema and a sort of blob where the bone looks a little bit odd, what we would describe as osteolysis. So we can't see a fracture line. Now, some of those will go on to fracture and others are just an overactive remodeling. And we sometimes see that towards the end of a healing process as well. So if I see that and they're quite early in the journey, I might put them into rehab, shut them down and scan at about 6 weeks, maybe 4 weeks if they're top level. And that's to make sure that we're not missing a bigger problem than we initially thought. And we're just diagnosing this as a bone stress. Typically for a routine pars fracture, I would scan at about 8 weeks. And the reasons behind that is that 3 to 4 weeks is probably too insensitive. And obviously there's a cost involved in these scans. And what I'm looking to try and do is sign them off from a scan perspective on an initial scan, an 8-week scan, and a 16-week scan. And what you want to see at the 8-week scan is bone marrow edema coming down, any fracture gap smaller or filling in on the vibe sequences. And then obviously the 16-week scan, ideally we're looking to see a closed fracture, minimal to no bone marrow edema. Obviously there are some exceptions depending on the size. If it's a 3-4 mil fracture, then often the 16-week scan is good and normal. If it's a full thickness that's taking its time, occasionally you may need to extend that. But I use that as part of the decision making alongside S&C and physiotherapy, depending on their strength and their symptoms, to push on various stages of their rehabilitation.
Fantastic. That was, I mean, it might be long-winded, but that was brilliant. Thank you. And it'll stick in my head now. Good vibes only. Like we're
Yeah.
no. Brilliant. Thank you. So useful. Ed, anything from that?
Yeah. So just a quick one in terms of the interval scans. Is that across the board, or would that just be in the elite sports setting? And I guess if we weren't able to use interval scans, can you sort of trust the symptomatic rehab process in terms of recovery, or would you want to interval scan everyone?
So again, listen, we live in a world where MRIs are much more readily available, but of course there is a cost element to that. Now, a lot of the patients that come through private medicine are privately insured, and I think that best practice is that with these injuries, the scans are incredibly useful in my decision making. I think if you don't have access to scans at all, then it's much more difficult, because the other tricky thing is not only are these often very little to find on clinical examination, if you shut the kid down appropriately, the vast majority within a week will be symptom free on testing. There will be some that will go on at, if they're still symptomatic at 4 weeks, then I'm asking questions as to this isn't behaving like I'm expecting. So the clinical symptoms and have they got pain cannot be used as a return to play marker. So that is one of the real difficulties. So if you can't scan them, really the only safe way is to say, okay, I've got a high probability of a pars fracture. They can't afford a scan, or for whatever reason, you can't get the appropriate scan. So you have to almost take them through a 4 to 5 month rehabilitation blind, or even take it out to 6 months. I think what the scans enable is a more appropriate, more sooner return to play. And again, if you can only, afford the 2 scans, I would probably going for the first one and the 8-week one.
Yeah.
Yeah.
Because that will give you that initial readout on where it's going to go based on what you've done.
It gives you the reassurance. And we know that these fractures, we know that there's a variability in healing, but pretty much if you are not using fancy adjuncts that we might use in a 21-year-old professional athlete, then it's not going to be healed at 12 weeks. Yeah, we know it's going to be longer than that. And if it's a full thickness, that might be 4 to 5 months. The ECB injury audit data is astonishing. For a fast bowler, the average return to play is about 230 days. So not only have you got to get them to a completely healed fracture, but then you've got to reintroduce a high risk, bowling and build them up. But there are some nuances around that. I'm very happy to talk about, early loading and how we try and prevent that a bit later on if you want to go through that.
Perfect. Yeah, no, we'll absolutely go into the rehab principles in a minute. And actually, just while we're still on scans, so you've scanned someone, you've got your results back. Is there anything that you would look for in the report that would make it maybe a more high risk injury, or something that you'd need to manage differently than the usual deload and graduated rehab program, or anything that would even require, surgical spinal input?
Yeah, so I think surgical spinal input is not required in the vast majority of cases if you've got someone managing them who understands the injury. That's not to say that they shouldn't see an orthopedic surgeon, because there's a lot of good orthopedic surgeons who understand this injury. There are quite a lot of spinal surgeons that I feel don't have a good grasp of this injury, and over investigate with CT or offer operations far too soon. That's where I think sport and exercise medicine has a real value in the vast majority of bone stress injuries. Sorry, I've lost my track there. Other things on the scan. So obviously, occasionally, if you have a very big fracture with lots of inflammatory change, you may see some irritation of the nerve root. But again, normally clinically, you've got radicular features. But I have seen that in a couple of players where they've probably been brewing it, and then they have a big trauma in a game. It fractures, lots of inflammatory change and ridiculous symptoms around it. So those are certainly the ones where I'll be involving the surgeons for an opinion relatively soon. Doesn't necessarily mean they need a stabilization of that, but I think those are the ones where you get a surgeon involved. I think the other ones that are high risk for me are either complete bilaterals. So if it's the same level and it's complete and it's fresh, edema both sides, those are high risk for me, because what we're trying to prevent by healing these is a spondylolisthesis, which is the long-term risk and sequelae. So a slippage of one vertebrae on the other. And if you think of the spine as a ring, if you've got bilateral pars fractures at one level, there's a much greater risk of a spondylolisthesis. Now, in an athlete, that leads to more chronic low back pain, disc degeneration, potential exit foraminal problems, and even other issues which are much more significant and then do need surgery later on. So if it's bilateral at the same level and complete, those are the ones that I would certainly consider bracing. The evidence for bracing is not great. You've got the one side, the big paper where they braced a load of kids. They braced them for about 6 months, took the brace off, rehabbed them, and said, what a great result. But, it was 8 months, 9 months where they were out. The ones where it's not been shown to have much of a benefit are where it's sandwiched down a little bit more. But my protocol would be that if you've got bilateral at the same level, or 2 levels on the same side, that are large or full thickness, or somebody where they're excessively hypermobile, or you don't think they're going to conform to not being active, those are the ones where I'd consider bracing.
That's really useful, because I think that's something that's always kind of scared me when I started managing these initially was, I'm confident I can manage this myself. I just need to know the safety aspects of interpreting the scan before I then implement the management. And that's really clarified that. I guess once you've then got that, if we take out the high risk ones, you're going to manage them with, principles of rehabilitation. But before you get to that in the clinic room, are there any further initial assessments in terms of blood tests and any sort of initial steps in management you would do from like a medical point of view?
Yeah, I think from a doctor point of view, I try not to massively over medicalize these. I think we know that vitamin D deficiency is a risk factor for bone stress injury, and we know that supplementation improves healing of those fractures. That's across all fractures, all stress fractures. So I'm not, if you've got a 13-year-old, I'm not hugely big on insisting that we check their vitamin D level, because I'm going to superdose them anyway, regardless. And I think that even if their vitamin D comes back as 100, I'm not going to accept that as they don't need vitamin D supplementation for healing of a fracture, because we know that the data shows that it improves fracture recovery. So I think if I was really concerned that there might be a malabsorption issue or a really significant intolerance or possible gastrointestinal disease, I might do a blood screen. I think the other thing is that if in the elite world, as they're older, if we were considering other adjuncts, I might be checking parathyroid hormone, vitamin D, alkaline phosphatase, testosterone, etc. In a very small number. The really complex ones, I might be looking at some of the bone turnover markers like P1NP, for example. But on the whole, they don't play a role. I think the other thing to be really clear about is that calcium is almost invariably completely normal. So, some people will just have a normal, what they call metabolic bone screen. They'll see a normal calcium and maybe a slightly raised alkaline phosphatase. The adolescents in those early phases of growth, the alk phos is going to be higher. So the vast majority of those you can forget about. And the calcium's always going to be normal unless they've got a metabolic bone disease. And I think I've maybe diagnosed one of those in, hundreds. So, the calcium we know is essential for homeostasis, for muscle action, cardiac function, all those other things. And what we see is that the way we get calcium in our body is dissolving our skeleton and then adding to it with our diet and our exercise. So if the calcium ever drops low, we just borrow some from the skeleton. And so I kind of try and get that across to people that you do need to have some, you need to really up your calcium in the time of the fracture repair, so it's not having to be borrowed from your bones the whole time. It's a very simplistic way of looking at it, but for patients, I think that gets the message across. So I tend to superdose vitamin D, 20,000 units twice weekly, and that'll be often for the duration until, certainly the first few months. And I kind of say to them, you can take like a child multivit with some calcium, but simple thing is pint of milk a day, a big milkshake once a day. And again, I do see a lot more kids coming through that are really picky about milk. They say, oh yeah, no, they're fine with dairy, and say, what about milk? Oh no, I don't like milk, don't drink milk. But again, I think those are the things that I would say from a simple thing. It's more a conversation about the things that they can do with their diet. The other thing that I'm very keen on is having a conversation very early about calorie excess. And that starts to veer into some of the other conversations about RED-S or abnormal thoughts around fueling, around body image, and that can all get very, very complicated. But I think what I say to my professional athletes and the non-professional ones is, just because you're not playing your sport now, I want you to still eat well and have, for our elite athletes, we'll aim for about a 300 calorie excess on a daily basis. And that's really just going back to very, very basic developmental animal biology. Most of us are, if we take ourselves back to the caves, you were going out, you were foraging, you were hunting, you were trying to get as much nutrient as you could. And we know that elite athletes are kind of on that precipice of being completely underfueled. And so what you want to do is send a very clear signal to your brain that A, the impact has come down, and B, that we're in the harvest season. There's plenty of nutrients around. We're able to get the apple off of the tree. We're able to get the meat. There's plenty going on here, and it switches the body into that anabolic phase. And I know it sounds a bit weird, but it's really basic animal biology that still, even though we've got smartphones, that's how our body still behaves.
Hugely insightful. I think that's a really nice and easy way of explaining it to patients as well. That's fabulous. So coming on to my topic of interest, being a physio, I'd love to know your thoughts on rehab. You've mentioned you work with some great physios. So how would you want those physios to work with the patients you refer to them, and what would the principles be?
Yeah, so I think that I can't take any credit for this because I work with some brilliant therapists, and I'm often led by them in terms of how they're going to develop these rehabilitation protocols. But I think that we've been doing some work with the ECB at the moment, trying to put together some guidelines and recommendations for this, because if you stick pars fracture into PubMed, thousands of publications, and I would say about 90% of them are from surgeons, surgical. There's about 9% that are maybe more medical review, a bit more leaning towards Red S, etc., and a bit more SEM bias. And then there's maybe less than 1% of those publications that are, this is how you rehabilitate it. There's maybe 2 papers that I've read that I thought that's quite useful, and that's in the entire literature for rehabilitation. So I think, certainly what we've sort of, the group of us that are working with the ECB together, and this is all their work also, is the first phase is that sort of protection phase. And that's really coming off aggravating activities, coming off their sport, and persuading them that they need to stop. So it's that protection phase of come out of the things that we know are going to make this fracture worse. And then the early stages of the rehabilitation is really just going to be basic stability and restoration of range of movement. Now, there's a lot of debate about should you rest them completely for 4 weeks, 6 weeks. And I must admit, my thoughts have changed over this a lot as the years have gone by. I used to kind of rest them for 4 weeks before starting anything basic. Now I would say that there's no contraindication to starting them on basic spinal stability from day one. I think that is useful. It helps. All these people are athletes. They're really active kids. They don't want to be doing nothing. I think if I had a big bilateral fracture, I might say, right, we're having a week of just total chilling, doing nothing. And then we start on the basic spinal stability. And those early phases are teaching them about stability and core stability and getting a normal range of movement. I think the next stage of that is much more functional, and that's looking at uniplanar spinal movement and improving stability in those areas. I think much later on comes building strength in multiplanar movements, then moving much more on to power and performance before sport specifics. But each phase may take 3-4 weeks, depending on the extent of the fracture. Whereas if you've just got a bone stress, no fracture, you might go through those phases relatively quickly, as long as the pain inhibition comes down quite quickly and they're a good athlete and they're already reasonably strong. That may take 5-6 weeks in a good athlete. In others, it might take a little bit longer. But I think that it needs to be phased from a cardio perspective. As soon as that you're happy as a therapist that they can maintain basic stability and a reasonable range of movement, then I think that cycling for cardio is absolutely fine. I think as you start getting a little bit into more movement in uniplanar, then things like cross trainer, swimming can be introduced, as long as they're not like high competitive butterfly. And then as they're restoring and building strength more in multiplanar, that's when we would start more return to running programs. And I'm very keen to get across the fact that with any bone stress injury, I think the basic physiology for bone repair does mean that early loading can be really good for that fracture. And that may be a tiny, tiny dose. We know that that bone metabolism gets stimulated with a tiny amount of a stimulus, and it might only need 7 or 8 of one stimuli to switch on those bone cells. Once you get up to 100 reps of one stimuli, the bone's not going to make any more bone than if you do 50. So the curve is very biased towards the early phases. So, with quite a lot of my lower limb stress fractures, we'll get them on double leg pogos week 1. As long as it's pain-free, crack on. And similarly with our spines, we're starting to do a little bit more of that sort of work very early, even when we're just doing the basic stability. And that might be twice a day, 2 sets of 8 of some pogos, for example, as long as we're happy that it's pain-free and that they've got good control.
Yeah. I think the pain-free is interesting. That's because I think that as a therapist trying to progress somebody through their program, I genuinely use that as a marker. Can you do this exercise pain-free? Does it recreate your pain? If it does, take it back and we just work on the early ones. But I think that can be quite a challenge sometimes for therapists to know how much they can push, because for many other conditions, it's quite normal for people to have some discomfort when they're doing exercises. So
yeah, absolutely. And I think, I think I said earlier, most people will be pain-free within a week, maybe 2 weeks. So you haven't got that to hang your hat on. You as a therapist have got to be making a judgment on, have they got a good range of movement? Are they stable through that range? How are they in the more uniplanar? What's their stability like in these? And then you start multiplanar, more challenging dynamic exercises, and you're looking much more at strength and stability, really.
and I suppose leading on from that, would you have any kind of rough timescales for return to play, and any particular objective measures that either they've gone through a really good rehab program, anything that would help you determine that somebody was ready to return to play?
Yeah, so I think that's what we're trying to nail down at the moment. And the problem is that there isn't the evidence out there. There's just nothing. If anyone can find the paper that tells you exactly what, then please send it to me. But it's not out there. There's some that say this is the rehab phases, and this is what we want to see before they can go to the next phase. But there's no mention of timeframes. And that's because, like I said, this is a spectrum disorder. And so someone with a 3 mil partial fracture who's got good spinal stability going into the injury is going to recover much quicker than someone with a bilateral total who is all over the place and not strong and growing quickly. I think that what we're trying to map out is the best practice of when to image and roughly what the phases of the rehabilitation look like, and using the imaging to help us make the decision about, part of the decision at least, of can they progress to the next phase. So it's kind of almost like therapist says, yeah, I'm happy that they're strong in this, they can do that, and the scan, I'm happy that the scan is doing this. So, okay, we're moving on to phase 2. And that's very much how we do it in professional cricket and with the professional athletes that I deal with these injuries.
You look like you're ready to ask them.
Yeah. Well, John, I think basically what you described in terms of like the initial medical management and the rehab, that is 95% of getting the right, outcome for these patients. I know that in some specific cases, there's a role for anabolic bone agents. So I was just wondering, really, who would you consider teriparatide for, and what's the sort of rationale behind its use in those patients?
Yeah, I will definitely come on to that, but realised I didn't answer the rough time frames question. I think the other nuance to that is certain sports will tolerate an earlier return to play. So depending on that particular sport. So for example, I will probably get a footballer back quicker than rugby, quicker than cricket. So the sport specific is relevant to the final stage of safety. And then onto the anabolic. So realistically, the anabolics, they should be viewed as a specialist input and medication. These are off-license, off-label uses of medications that we use in osteoporosis in a much older age group with a completely different demographic and for a completely different use. But we've had quite a lot of success utilizing anabolic agents like teriparatide, and just to be clear, anabolic doesn't mean it's banned. Anabolic just means it's growing stuff. And so, we've used teriparatide, which is a parathyroid hormone analog, which is an osteoanabolic agent. It's been around for about 20-25 years. The sort of post-release data is that it's very safe. It's not like a bisphosphonate, which hangs around in bone. There's no evidence that bisphosphonates accelerate fracture healing. So it's not that whole group of drugs we wouldn't use in these sorts of patients. But teriparatide as a parathyroid hormone analog has a short method of action. It spikes. The parathyroid hormone spikes very quickly. It's out of the system within a couple of hours. And we know that with pulsatile dosing, it's osteoanabolic. So it increases bone turnover, but increases bone building more than bone demolishing. So you get a net gain in bone density, but also it's got a very good track record, mainly in surgical non-unions, often with metalwork, or not with metalwork. It's got a good track record of use and a safety profile from that, where it's been used off-label in orthopedics. So I think that, for me, I think it is an option. The main sort of contraindication is unfused epiphyses, so they have to have fully grown. And so that's part of the conversation. So a lot of the non-elite athletes that we see with this are, good school cricketers, good county cricketers, academy level, whatever. It's not conversation. We're not going to be using these drugs. If you have got a professional athlete at a club or right at the top of the academy, just going into adult sport, if they're fully physically mature, then there's a conversation around it. And again, obviously, most of our role in elite sport is trying to return people to play quicker, but safely. And so there are nuanced conversations about, what are the risks around the drug? What's the benefit? What's the cut-off time? But certainly in our cricketers, I would estimate that, if we compare what we've done at Surrey with the national ECB injury audit, of 240 days, we're pretty disappointed if we've not got someone bowling at 180 days. And some of those have been sooner than that. So, it's not insignificant. Some of that is the protocols, the nutrition, the fact that we're evolving in sport. But I'm pretty sure that some of that is also down to the drugs.
So from that perspective, then it's RTP and increase bone union potential as well. So you got both sides of it.
Yeah. It's allowing you to move up the phases quicker.
And I guess you just very briefly touched on the non-fused epiphyses as the absolute contraindication. Is there any other safety considerations, or is generally quite safe otherwise?
That's the main one. There's a whole list of other stuff. Reeling them off, pregnancy, unexplained alkaline phosphatase, previous radiotherapy, previous bone tumor, possibility of metabolic bone disease. And again, that's probably the main one for why this should be a specialist prescription, in my opinion. You want to rule out other metabolic bone disease before you would use a drug like this. And that's mainly rheumatology, endocrinology, as the people that manage those conditions on a regular basis.
And you touched a little bit there on kind of future of managing and some of the work you've been doing with the ECB. Can you give us any insight into how things might progress in either the future of management or prevention of of pars injury from your perspective? Is there anything you can think of?
Yeah, I mean, certainly, I think that the incidence is going up, and and that is partly due to a number of factors. I think that you've got a lot of talented athletes who are kids who now, compared to 20 years ago, have got much more access to playing more sport. They're physically maturing quickly in terms of they've got access to S&C from a very young age. The intensity and skill level has gone up. Their speed has gone up. So the injury rates are going up because the forces are greater and the load is greater. So I think that there's a massive piece that needs to be done on education, and that's got to come from professional academies, in my opinion, as the first starter. And I think if the professional academies are adhering to much more load management, nutrition guidelines, recovery, then we'll see the really at-risk kids who are playing multiple sports to a high level, they'll be more protected. I think that then needs to feed down to schools, which is a lot harder because there's a massive variability, as we know, in what the school access is going to be. But I think it's really getting the education also out to the parents who, I'm sure all of us that work in sport see that there are some parents who are really safety first and kids got to enjoy it. There are other parents who are maybe not quite so close to that. And that's got to be part of the education piece also. So education is really the only way that we're going to prevent more of this happening. I think that if we have more guidelines, and like I say, what we're writing at the ECB is guidelines. It's going to have the best evidence base that we can, but it's going to be opinions and views of a lot of people who work in this area and have a lot of research in this area, a lot of work in this area. So at some stage, we've got to put something down as this is what we recommend as a rough guideline with timeframes, scanning intervals, etc., and then research against it and audit against it. And that's the only way that we're going to get better at managing these. I think at the top elite level, are there other drugs that might come into play? Possibly. There's a couple of other osteoporosis drugs out there at the moment. Romosozumab is the kind of new kid on the block, which tends to have slightly better results than parathyroid hormone in osteoporosis and fracture management. But actually, the early studies on does it improve fracture repair were negative. So it may be that it's got a slightly different method of action. That's probably, don't want to go into detail on that on this. People will be falling asleep. There's another one called abaloparatide, which again is a PTH analog similar to teriparatide, but it's got a much shorter method of action. So the studies suggest that it has the bone growing capacity that teriparatide has, but it has much less of the osteogenic, the getting rid of old bone effect that the teriparatide has. It's probably going to have a slightly better fracture rate, maybe, but we don't know. There just isn't the data out there. But obviously, people aren't developing drugs to treat past fractures, and we're kind of just borrowing this from osteoporosis. And like I said, across the spectrum of junior athletes, it's going to be a tiny fraction that we're going to be using drug therapy in. And they are, like I said, they are going to be fully grown professional athletes that we're using this drug for.
Amazing. I think there's a definite call to arms for physios to start doing a bit more research on the rehab medicine things. If anybody wants to get into research, sounds like a great area to be working in. Fabulous. Anything from that, Ed, again?
No, I think that's covered everything. I think, and like you said, John, just around the education, it really is about bringing that whole MDT into it, including coach and staff, because that is really where when people see these managed, and having prolonged time out, that's where everyone starts getting invested in the prevention of them. And I think a little bit more sort of raising awareness around the sort of sports settings, whether it be grassroots or elite, within the MDT will really help with that prevention piece.
Yeah, I will give one quick shout out. So Angela Jackson, who's fantastic physio that I only met last year, but she sees a lot of kids who don't have access to MRI scans, very experienced, but she's got a great website, kidsback2sport.com, which is kidsback, number 2sport.com. On that, lots of free resources around load, diet, fueling, and it's a great website for patients, for coaches, for kids. I think that's a great starter just to look at. And, certainly she has a number of physios that she's trained. And again, if you're looking for a practitioner, that can be helpful.
Amazing. We'll make sure we add that to the podcast notes. So thank you for that. That's brilliant. I'm just blown away. I've learnt so much from talking to you tonight. It's been fantastic. Thank you so much.
Yeah, I'll be going back and listening to this regularly. Refresher. I might even take some notes next time I listen to it as well, because it's simplified a topic that I think a lot of clinicians often spend time tearing their hair out over, and I'm really, really grateful for it. So yeah, I think
Pleasure.
Pleasure.
Okay. Unfortunately, I think it's one of those topics as well that the more I think about it, the more questions that I have. So yeah, we're evolving, but I think we have to draw some lines in the sand, because it's, if you think about this as an injury, how common it is, the guidelines, the advice out there is just so poorly researched. So, it's an area that's kind of been ignored for a long while.
Yeah, the potential sequelae of events as well, the long-term effect that this can have on athletes, both career-wise and for long-term health. It's really important that we're recognising these and managing them well. Excellent. Thank you so much. It'd be great.
Pleasure.
Thanks, John.